And I would like to say you gave me something that has just a ridiculously vast differential. So thanks for that. It was tough to decide how much in depth are we going to talk about at the very beginning here, because there's lots of crazy causes of hypercalcemia. But so I want to start by saying that just recall that calcium is bound about half to albumin in the bloodstream. And so whenever I hear about a calcium disorder, my first question is that calcium real? And so how do we decide that? Well, if it's half bound to albumin, albumin will affect it, right? So ideally, we get an ionized calcium level. But of course, ionized calciums are difficult to get because they have to be kept on ice, which means about half the time they get done wrong and they sit around too long. So in lieu of that, we can do a corrected calcium. So how do you correct a calcium? For every gram per deciliter of albumin below 4, you add 0.8 to the calcium. So this probably won't come up in this case, because most often we adjust for low albumin levels, and then you'll end up increasing the calcium. And so hypercalcemia, even if it's uncorrected, is rarely artifactual. But I just wanted to mention it here so you guys keep that in mind. Okay, so hypercalcemia, what are the big things? So 90% of causes of hypercalcemia are caused by one of two things. So one is primary hyperparathyroidism, and the other is hypercalcemia of malignancy. And those really diverge in two very different directions. So primary hyperpara is the most common cause of outpatient hypercalcemia, tends to be mild, present for years, whereas hypercalcemia of malignancy is a much more acute problem, right? So the most common cause of inpatient hypercalcemia is hypercalcemia of malignancy, usually higher levels of calcium, more acute. So I'm assuming perhaps that's where we're going, but who knows? That only makes up about 90% of hypercalcemia. There's another 10%, and those things are wacky, all kinds of things. All right, so let's go a little bit more in depth. So the first thing I want to know when you tell me a patient's hypercalcemic is, what is their parathyroid hormone level, right? Because we really group things into parathyroid hormone mediated and non-parathyroid hormone mediated. So primary hyperparathyroidism, as I mentioned, usually benign, happens over years, most commonly caused by a benign adenoma of one of the 4 parathyroid glands in the neck. It can be associated with some genetic syndromes. The most common ones that you guys probably know of are multiple endocrine neoplasias, both types 1 and 2. And there's a couple other more rare genetic syndromes. These are most commonly associated with parathyroid hyperplasia. So hyperplasia of all 4 glands as opposed to a single adenoma. And then finally, tertiary hyperparathyroidism is on a continuum with secondary hyperparathyroidism. Most common causes of secondary hyperparathyroidism are vitamin D deficiency, but then renal failure, which is where we see tertiary hyperparathyroidism. So basically, as the kidneys fail, the kidneys have the 1-alpha hydroxylase enzyme that converts 25-hydroxyvitamin D, the storage form, into the active form, 1,25-dihydroxyvitamin D. And so when you lose function of that, calcium levels will fall, PTH increases as a compensatory mechanism. Over time, this causes those parathyroid glands to hypertrophy, so you'll get hyperplasia of the parathyroids. If this goes on long enough, they sort of escape regulation and you get hypercalcemia. Okay, so the transition between secondary to tertiary hyperparathyroidism is defined by that switch from low calcium or normal calcium to high calcium. Okay, so that's our kind of parathyroid hormone mediated causes. Interestingly, if you have primary hyperparathyroidism, you're more likely to have malignancy. And if you have malignancy, you're more likely to have primary hyperparathyroidism. So there's some possibility that we'll have an intersection of two things in this case. We'll see. So non-parathyroid mediated causes, the big one is hypercalcemia of malignancy. And there are kind of 3 mechanisms where this happens, mediated by different hormones. So PTHrP, or PTH-related peptide causes, are probably the most common one we think of when we think of hypercalcemia of malignancy, most commonly caused by squamous cell carcinomas, like head and neck and lung, and then also breast cancer. but there's all sorts of crazy case reports of obscure tumors that secrete PTHrP. So that's always a possibility here. Some tumors actually turn on that 1-alpha hydroxylase. So usually we think of 1-alpha hydroxylase as predominantly in the kidney, but it's present in many cells, including immune cells. And so there are some tumors that will turn on 1-alpha hydroxylase. So you hyperconvert 25-hydroxy to 1,25-dihydroxy vitamin D, causing hypercalcemia. So there are some types of lymphoma that will do this. And then finally, a lot of osteolytic mets that release lots of cytokines and activate those osteoclasts can also cause hypercalcemia. Classic example of this is multiple myeloma. Okay, so there's like the most common causes of malignancies. You can also get, outside of malignancy, we can see hypercalcemia with vitamin D intoxication. So recall that vitamin D is a lipid-soluble hormone. And so when you ingest vitamin D, it's rapidly converted to 25-hydroxy vitamin D and then stored in fat. So that's why that's what we check to see whether someone's vitamin D deficient. Usually there's careful control of whether or not you convert 25-hydroxy vitamin D to 125-hydroxy vitamin D. But if you take in too much vitamin D, you can sort of overwhelm the system and get hypercalcemic. This is pretty rare. So a lot of people take vitamin D. I take a lot of vitamin D. And there's a wide therapeutic range, right? So we look for levels of around 30. Toxicity doesn't usually develop until you hit like 150 or so, but we do see it causing hypercalcemia in rare cases, usually with kind of crazy high doses. There was one patient in the endocrine clinic one time who was taking, it turned out was taking 50,000 units daily instead of weekly for like months and months and months. I don't know how they kept refilling their prescription. They did not get hypercalcemic. So don't worry, you can take a lot of vitamin D. It's good for you. You probably won't get hypercalcemic. Okay. The other cause that's sort of similar, vitamin D mediated, is anything that turns on that 1-alpha hydroxylase to make excessive 125. Sometimes that's malignancy, like we mentioned, but also any chronic granulomatous disease can do it. So the classic ones that we see a little more commonly here in St. Louis are sarcoidosis, and then sometimes histoplasmosis can do it. But there's all kinds of crazy cases of this. So TB can do it. Tertiary syphilis sometimes forms granulomas and can do it. We were just talking amongst our little endocrine groups that you can have reactions to any type of implant. And so there are actually reported cases of like butt implants that then caused hypercalcemia from excess of 125. So make sure you ask your patients about their implants. But there's all kinds of skin conditions and other causes of granulomatosis that can do it. Okay, so those are our two big sort of hormonally mediated groups. And then there are a number of meds that are common that I just want to mention really briefly. So you always want to take a careful medication history in these patients. So thiazide diuretics will cause you to absorb more calcium at the levels of the kidney. Usually they're not the primary driver of the hypercalcemia, and it's more that they will unmask primary hyperparathyroidism. So in anybody who has hypercalcemia on a thiazide, you should still evaluate them for possible primary hyperpara. Lithium can do it. Lithium actually alters the calcium sensing, and that can actually cause a mild hypercalcemia. The anabolic bone agents that mimic PTH, that are parts that look like PTH, can actually increase calcium after you use them. That's usually a little bit more transient. And then in rare cases, we see excess vitamin A causing hypercalcemia. Do you guys know what the classic like source of excess vitamin A is? Polar bear liver. It's like endocrine trivia 101, right? So if you eat a lot of polar bear liver, it has a lot of vitamin A, so try to avoid that because you might get hypercalcemic. And then I don't think anybody uses theophylline anymore, but apparently that can cause hypercalcemia. Finally, there's a number of sort of like overlap syndromes with other endocrine things because endocrine things tend to run together, so that's fun. So hyperthyroidism can sometimes cause hypercalcemia, probably just because of increased osteoclast activity. I'd say we see this quite rarely. I don't know that I've ever seen hypercalcemia purely from hyperthyroidism, and I take care of a lot of hyperthyroid patients. Acromegaly can cause hypercalcemia, but the most common reason is actually because it can just be associated with primary hyperpara, but there are rare causes where it turns on that 125. The growth hormone probably stimulates the 1-alpha hydroxylase a little bit. Pheochromocytomas have been reported to actually produce parathyroid hormone. Adrenal insufficiency isn't a super clear mechanism, but maybe also related to increased bone resorption and volume contraction. And then immobilization is kind of a diagnosis of exclusion. I think I diagnosed that once in the hospital because we just couldn't figure it out. And it's thought to be from decreased weight bearing causing increased bone absorption over time. And then really quick, I'll mention milk alkali. I already mentioned it once, but usually related to lots of ingestion of calcium-containing products concurrently with some type of alkaline product. So the most common is calcium carbonate. So people are popping Tums like crazy for their GERD, and then they come in with alkalosis, renal failure, and hypercalcemia. There's a awesome review. If you guys are bored, it's just really entertaining. It's good Friday reading. There's a review from 2021 by a guy named Bill Zekian, who kind of does all this parathyroid stuff, who looked at rare causes of hypercalcemia and basically found every crazy case report on hypercalcemia ever written. And one of them was a lady who got milk alkali because she was chewing too much nicotine gum, and that had a lot of calcium, and then she was drinking a lot of carbonated water, and she got milk alkali. And so it has a lot of really obscure causes. Okay, so that's sort of an overview, and now let's go back to our case a little bit, and I just want to circle to what did the points in the one-liner sort of make me think of? Mm-hmm. So the first thing in the one-liner I got was hypertension. Okay, maybe the patient's on a thiazide. That would be really boring. I'm going to doubt that that's it, but it's possible. Maybe that patient has acromegaly, because that would be unusual and fun and could be more associated with hypertension, similar to pheochromocytoma. So pheochromocytoma usually causes like an episodic hypertension, but maybe we'll see. COPD, maybe that person is a smoker. Maybe they're more likely to have some type of lung or head and neck malignancy that's contributing to this. Maybe they're still on theophylline, but almost nobody's on theophylline anymore. Maybe they have adrenal insufficiency. Maybe they've gotten a lot of steroids for COPD exacerbations, and now they have secondary adrenal insufficiency, and that's manifest as a little bit of hypercalcemia. We mentioned our patient has CKD3. Could they have tertiary hyperpara? Probably not. So usually, stage 3 is kind of when secondary hyperparathyroidism is starting to develop, and it takes a while. So it's usually patients who are end-stage renal, or at least substantially more progressed before you would develop hypercalcemia and tertiary hyperparathyroidism. So I think that's probably unlikely to be related, but maybe this person has impaired kidney function that's going to exacerbate everything. And then finally, this patient has a history of prostate cancer. Maybe they have metastatic prostate cancer. Is that doing it? Again, I think that's unlikely. Prostate cancer is much more likely to cause osteoblastic mets. And those aren't associated with hypercalcemia, right? We're looking for those osteolytic mets that cause absorption of bone, and those are usually what contribute to the hypercalcemia. And now we've added diabetes to the mix, and I can't really think of anything that would necessarily contribute to that, unless, again, this person has steroid-induced hyperglycemia, and so they've been on and off steroids, and maybe now they have adrenal insufficiency. But again, hypercalcemia related to adrenal insufficiency, also rare. Okay.
Well, thank you so much for laying that foundation. You're clearly an expert, and I am so much smarter now. And I know so much more about hypercalcemia than in my entire career. So thank you so much. And it was really hard too, because I feel like you already figured everything out. So yeah, let's keep going and learn a little bit more about the patient. And just really quick aside, I guess I was supposed to do my picks of the week too. The Pit, yeah, incredible show. It's so therapeutic. I love just like shouting at the TV about like all of the things that I want to do for the patients themselves as well. But it's like an incredible show. Like, please watch it. Please tell your family to watch it so they like actually understand what your job can be like. Um, we've been trying to get back in the pub trivia scene. We recently did like gallery pub trivia, which is Tuesday nights. We were in first place, tied for first place until the very last round, and then we dropped a fifth. So I guess I will never win at trivia. And then the top picture, I guess it's a pick of the week for my daughter, but she's really into magnet tiles right now. It's like this hot new toy that all the kids really love. Yeah, Dr. Chang agrees. She can like entertain herself for hours and she can like build towers that are taller than herself. So it's really fun. And then she also discovered like a bubble gun. So it's like great for the summer too, but it's like a nonstop, like reloadable bubble gun that just like shoots bubbles. So that's, I just wanted you to know, I guess. All right. So back to the one-liner. I think Dr. Riek did a fantastic job of breaking everything down, and let's give her a little bit of an HPI on the patient. So this has actually happened in the past for the patient. So you're seeing him now for hypercalcemia, but kind of on further review, you realize he's had 2 hospitalizations within the past month due to hypercalcemia as well. During his prior hospitalization, he had kind of symptoms at the time. So for one of the hospitalizations, he reported some weakness, gait instability, several falls. They treated his hypercalcemia and improved. He discharged. Those symptoms had resolved. Then for his most recent hospitalization, all within the past month as well, he was actually lightheaded, also found to be hypercalcemic, had noted specifically like symptoms were maybe worse with positional changes. Then the same thing happens. They treat it appropriately. It's like more stable. Symptoms resolve. He discharges. Both of those hospitalizations occurred at the VA. So while you're hunting down the VA records, you're kind of like trying to think about what to do for this patient. And he did, have a full workup both times. And both times, despite that, we still don't exactly know what's going on with the hypercalcemia, which is a little interesting. And yeah, currently he's in the VA ED. He had done some outpatient labs. They found calcium of 13.7 on them. And this is pretty comparable to the prior 2 hospitalizations, like that calcium level. But currently he's actually feeling pretty well. He doesn't know any new symptoms and then doesn't know kind of those specific symptoms that he had in the prior 2 hospitalizations. So does this give you anything, or does it just open up more questions?
Mostly opens up more questions. Scares me a lot because I know a lot of endocrinologists at the VA. So if it's figured out, that's like, a little bit of terror, but that's okay. We'll go with it. We'll go with it. Doesn't help a whole lot. The symptoms of hypercalcemia can be sort of non-specific. So we think of the sort of like stones, groans, moans, psychiatric overtones. A lot of it is sort of the blahs. People can get profound dehydration, which is probably explaining a lot of what he has. Lightheadedness, orthostasis, weakness, falls are pretty common with hypercalcemia. So it doesn't necessarily help me a ton, except to say, yes, this man is hypercalcemic and probably seems so. It is pretty high. I mean, they did get him down to normal on discharge, which is interesting, but he's up to 13.7, which is a more severe hypercalcemia. So it would make me concerned for some of the bad things. This would not be a typical picture of a usual like primary hyperparathyroidism, even though it's been going on the order of months. His levels are a little bit high. The vast majority of those patients are asymptomatic. So I guess the only thing I would say is that it makes me a little bit more concerned for some of those other causes of hypercalcemia, more down the sort of like malignancy or granulomatous disease routes.
Okay, awesome. And when we get to kind of like the objective section, you'll be able to ask for like any of the testing that he's had before. Okay. And then kind of an aside about his prostate cancer history seems good to know too. But 8 months ago, he had labs, had elevated PSA then, formal diagnosis and biopsy was 4 months prior to when you're seeing him. Status post this prostatectomy 2 months ago, had been doing like relatively well since then. But I guess in the interim, of course, like the hypercalcemia stuff was being actively managed, and has some chronic urinary symptoms, but no change. Chronic decreased appetite with kind of this 16 to 20 pound weight loss over this past 6 months, but of course overlapping with the recent cancer diagnosis. And then it also has like this interesting, like unexplained history of some intermittent syncopal episodes and pre-syncopal episodes. I think for the pre-syncopal ones, they're kind of described as like dizziness, lightheadedness, very transient, kind of nothing really preceding it. the syncopal episodes were like much more rare. So all kind of interesting, a little odd. And then he's getting like a workup that's kind of occurring like separately, but just like as an FYI, maybe. Yeah.
Not a whole lot of additional thoughts. Again, the urinary frequency, I'm not super surprised by. If his calcium's high, that's going to cause a diuresis. And so he's probably dehydrated. I think that may be contributing to his syncopal episodes. Concerned about the decreased appetite and unintentional weight loss. Again, that sort of like leans more towards that large group of malignancy associated.
Yeah. And like Dr. Riek said from the beginning, just give her the PTH and she'll know what to do from there. And of course, we're holding out and making her wait. And just to round him out, some of additional medical history, I think the most significant ones we covered, family history, in case any of that you think is related. Those are his medications, because I know we kind of focused on that, especially with the hypercalcemia table too, and then just his social history too.
So the things that jump out at me on here, does have a mother with RA, so does have a family history of autoimmune disease. So are we looking at one of these autoimmune disorders that may cause granulomatous disease? Could he have Crohn's? Could he have sarcoid? A little bit of an unusual demographic, but hey, it's CPC, it could be anything. He's on Advair, and so maybe the Advair is enough. Sometimes it's pretty rare to actually see the development of overt adrenal insufficiency from the use of Advair, but it is possible. And like I said, he may have gotten other steroids. It does, suggest he has ongoing treatment of his COPD. And then he's on a vitamin D3 supplement. So it notably doesn't have a dose there. So I don't know, maybe he's taken boatloads of vitamin D. Is a former smoker and just quit a month ago. So again, higher risk of malignancy. So lots of little things we can sort of pluck out here that may be suggestive.
Okay. And then just review of systems, just in case we missed anything. I think the only thing we really gained, he had some constipation, which it really just popped up in the review of systems when I looked through his chart. And then the facial rash as well kind of just randomly appeared. But I think some of the other stuff we had already established for him. Maybe fatigue was something he hadn't explicitly mentioned prior.
Yeah, I would say pretty typical, again, sort of inconsistent with hypercalcemia, but not super revealing.
Okay, great. I think we have like a great basis for your thoughts at the moment. And then physical exam, I'm sure you would like as well. So he's like vitally stable, nothing like really too impressive. I don't know why, just like the rash really bothered me. So I just made sure I mentioned it in all the ways.
Facial hypopigmentation.
Yeah. There's no pictures. I don't even know where on his face it was, but
vitiligo, autoimmune thing.
Okay.
Otherwise unremarkable. Okay.
Okay. So let's not delay you being able to start your workup in diagnostics. So this is a menu. I will say there's certain things that I'll do in a certain order. So maybe I'll just pick myself. Cool. So if it's okay with you, why don't we start with the initial labs?
Yeah, I'm an endocrinologist. All the labs. I want all the labs.
Can one of the chiefs help me change this into the pointer mode? Control L. Okay, thank you. Yeah, okay. So this is his labs from when he first went to the VAED. So 13.7 was on his outpatient labs. Now he's in the VAED. It's like the tiniest bit better. 13.5 hasn't been treated. Creatinine's 2.33. I think his baseline is actually closer to like 1.5 to 1.8. So we're like AKI, CKD, AKI on CKD territory. And then some mild anemia as well.
Okay. So he has pretty significant hypercalcemia, right? So 13.5 is a high calcium. Again, this wouldn't really be consistent with a usual case of primary hyperpara, where we don't commonly see calcium levels above 12. He's got a significant AKI associated with that. And again, some of that may be the dehydration from this, pretty severe hypercalcemia. He doesn't really have an alkalosis, so it doesn't look like milk alkali. He does have a little bit of a high protein and a not super high, but decent protein gap. So that makes me think myeloma, right? So renal failure and hypercalcemia. and a protein gap sort of says, okay, but could certainly be a concern. Also has a little bit of anemia to go with that. So myeloma is definitely something that's fairly high on my list at this point, but also just like overall malignancy. He sounds a little sick.
He sounds a little sick. And then, so he's in the VA for like 5 days. I guess some stuff happens, which we'll get to, and then he's at Barnes. And then these are his like Barnes labs when he first comes to see you.
Happens.
So yeah, so his creatinine improves, his calcium improves. The calcium is like post some interventions that happen, keeping it vague still, I guess. And then the other labs like look pretty similar as well. So again, maybe doesn't add too much additional. So we did that. How about we check on, his EKG and his chest X-ray, because that was done. And yeah, so he had a right bundle branch block. This was like seen on a prior one. So I think that the team at the time wasn't like super concerned when they had seen that EKG because it was pretty stable. And then for his chest X-ray, there's like commenting on some probably like baseline emphysema for him, and then some like kind of more dispersed opacities. And I think the radiologist said maybe mild pulmonary edema. Does our radiologist in the room see anything that I'm not commenting on? Okay, great.
Wait, say that again. What did we call?
So I think the radiologist commented on like some baseline emphysema for him, some like bilateral opacities, and then like a mild amount of like pulmonary edema.
Huh, interesting. So nothing super helpful here. I mean, we think of things, I don't actually remember what the EKG changes are if we think of something like cardiac sarcoid. But let's keep going.
Yeah, let's keep going. Let's go through the list. Okay, urine studies you got, and this is what it showed. His A1C is 6, interestingly, but he had a lot of glucose in his urine, and he had some protein as well, but otherwise was negative for infection.
Okay, so not super remarkable, probably not super helpful. I mean, he does have diabetes, he does have CKD, so I'm not super surprised by this.
I hope you have nowhere to be because I feel like I'm just taking up your time at this point doing random things. Oh, sorry. I should ask you, what do you want to check for infectious workup? You mentioned some of it. So you mentioned like if you're thinking granulomatous disease and things like that.
Yeah. So the big ones I would think of are TB, histo, blasto.
Okay.
For infections that would be associated with granulomas.
Okay, great. And the team agreed. And that is what they found. So negative as well for that.
Okay.
Okay. So I think we're at a branch point where we could either go straight to the endocrinology workup or talk about our imaging. So which would you like to do, Dr. Riek? I think I know.
PTH level.
Okay.
Done that days ago.
No, we could have been done already. So PTH level for sure. And then I know you had referenced kind of along the way, like some of the other things you were thinking of. So we're ordering PTH. What else should the team put in for their orders?
Yeah. So the way I usually do it is I get a PTH off the bat, and then I usually get a 25 hydroxy vitamin D because I can get it back faster. And then if it's non-PTH mediated, then I get a 125 level and a PTH-RP, mostly because I have to fight with a lab medicine resident at that point. And so I want to make sure that I have a good case before I go down that route. And I get both at the same time because they're both send outs and they both take a long time to come back. So that's usually more helpful. So those are kind of like the big ones that I want. Okay. And then depending on how those look, that's when we start sort of looking at a malignancy workup with imaging, SPEP, UPEP, serum free light chains. Okay. And that's kind of where I'd go from here.
Okay, that sounds great. So your endo workup as requested. So this was from like the most recent labs. I think we saw the iCal kind of the same day. It was 5.47, so like mildly elevated. And then I'll let you take a look at the other results.
Okay, so the calcium is high, right? And we've confirmed the hypercalcemia with an ionized calcium that's also high. So that's great. And that's a relatively normal phosphorus level, which again suggests that it's probably not going to be PTH based because that would drive the phosphorus down. And so we commonly see hypercalcemia associated with hypophosphatemia in hyperparathyroid. Look, we checked for thyroid disease. Yay, normal. So there's my PTH. So the level is 12, right? So this is a pretty low PTH. So one thing I just want to emphasize that we keep in mind, because it comes up all the time in primary hyperpara, which this is not, But if you have a normal or sort of high end of normal parathyroid hormone concurrently with hypercalcemia, your patient still has primary hyperparathyroidism, right? So this is like critical endocrine 101, like feedback loops, right? When the calcium is high, PTH should be low. So if it is high, that's abnormal. But if it's normal, that's actually inappropriately normal. So when you come rotate with us, we'll talk to you all the time about how that's inappropriately normal. And so that would still be consistent with the diagnosis of primary hyperpara. That being said, full suppression of parathyroid hormone is down to like the teens or so. So it never falls to zero like some hormones do, like TSH, you guys see it all the time. TSH goes to zero in response to feedback, but parathyroid hormone will only go down to about the teens. So basically this is as suppressed as that PTH is gonna get, and this is not PTH mediated hypercalcemia. Okay, so our 25 hydroxy vitamin D level, and recall that's a stored form of vitamin D, is actually a touch low for the level we usually shoot for, which is 30. Lots of controversy about that. But our 125 level is high, right? So it's 96. So this is clearly 125 mediated hypercalcemia. There you go. My job is done. So the next question is always, well, now where's it coming from, right? Because we talked about a whole lot of things that can turn on 1-alpha hydroxylase and cause 125 mediated hypercalcemia. Okay. Oh, I didn't even see that. We got an 8 a.m. fasting cortisol,
Yeah,
less than 12. That's a very high cutoff.
It's from the VA. I didn't, yeah. That, like they did it at the VA. I was also, it was like a treasure hunt trying to figure out like what test happened and what the result actually was, but that was the best I could find.
Huh, interesting. But the stim test was normal?
Yes, yeah.
Okay.
Reportedly, yes.
So just so you guys know that they have sort of honed in the assays for cortisol. And so now it takes a lower level than it used to call someone adrenally sufficient. So a random level of probably 11 or 12 rules out adrenal insufficiency, and then a stimmed level to about 15 rules out insufficiency. So it sounds like this patient ruled out, but an important thing to know about cortisol, because the cutoffs have changed, but the newer assays are better. I have no idea what the normal range is on
I don't either.
vitamin A, so I have no idea if that's normal. 30 to 50? Oh, perfect.
Great.
Thanks, Dr. Reed.
Thank you for confirming.
So that is a normal vitamin A level, so it doesn't seem to be vitamin A toxicity. And our patient has decently well-controlled diabetes, or their anemia is bad enough that it's artificially low, and they actually have blood sugars of 350 all the time.
Okay, great. So let's take us back. And kind of like I referenced before, the hypercalcemia had been worked up before. You actually know, a month ago, he had a CT abdomen pelvis that was clear. It didn't show like lymphadenopathy or anything acute. And then he had a low-dose lung CT, I think kind of like just done as screening, and it did not show anything abnormal either. But I will say we have a radiologist here to tell us about some additional imaging studies we did. So is there a specific one that it kind of pops in your mind for us to try?
For 125 mediated, I guess probably chest first, I would say. Because I'm thinking about things like sarcoid, lymphoma is so widely variable. I'm a little surprised that nothing came up if it was going to turn out to be lymphoma.
Yeah. Yeah. So we did do more advanced imaging, and if it's okay with Dr. Short, we'll have him come up and kind of talk about that section now. And we do find things actually. So let me get us to that screen. Just go past these ones. Okay. And then these should be yours.
All right, and they did get a chest CT here to start off. So we have some axial images from a contrast enhanced chest CT. I've kind of come down just on the mediastinum here. There were no findings in the lungs. And what you're seeing here as we march down the contiguous slices is low right paratracheal lymph nodes that are enlarged, more than 1 centimeter in size is kind of our cutoff for that. A right hilar lymph node that's also enlarged, a subcarinal lymph node, and then a left hilar lymph node as well that's enlarged. I can't remember how long ago they had the low dose CT Really, just a month. Interesting. I mean, so those are sometimes so low dose that it's a little bit harder to see lymph nodes that are kind of borderline enlarged. So yeah, that's kind of interesting. Differential diagnosis, of course, for mediastinal and hilar lymphadenopathy, sarcoid, as you've been talking about, lymphoma, and I'd never bet against primary lung cancer in a VA patient here. We didn't see anything in the lungs that looked like a primary, but small cell lung cancer can sometimes manifest primarily as lymphadenopathy. The patient actually went on to get a PET CT, and you can see, not surprisingly, I think for mediastinal and hilar lymph nodes, a lot of times PET is not particularly helpful. If they're enlarged, they're always going to have a little bit of uptake. And these lymph nodes indeed did have a little bit of uptake, as you can see there. Would be helpful to, scan the rest of the body. And what was found there were a couple interesting findings. There were some peripancreatic lymph nodes. There you can see on screen left that also had some increased FDG uptake. And then the spleen, I've kind of given you the full body shot there where you can see the mediastinal lymphadenopathy, but also the spleen, which is increased in FDG avidity compared to the liver, which is abnormal. So some sort of splenic involvement, which would make lung cancer pretty unlikely. You'd still be thinking about leukemia, lymphoma, sarcoidosis, and then I didn't mention granulomatous infection, but that would of course be a consideration with this constellation of findings.
Let me see if there's anything additional there. Okay, and then this was just kind of like FYIs. I don't even know if you care to know the rest of some of the studies that they did, but they did an echo. Interestingly, like this epicardial fat pad comment was just like mentioned, cardiac MRI, some like thickening, and then they did a brain MRI as well and didn't show anything acute. And then just to make sure I told you that, the prior study, so we talked about the CT abdomen pelvis, the low dose lung cancer screening, and then there's a renal ultrasound done as well.
And so that was the VA workup that was negative previously?
Yeah.
Okay.
Yeah.
Okay.
Okay. So I think that's kind of the extent of our imaging studies. What do we have left on the board to talk about? I think it might just be additional workup and pathology. So for additional workup, you kind of mentioned some of kind of the lingering labs or lingering things to follow up. So could you just remind me again what else we'd want to check on them?
I mean, I don't know how far down the rabbit hole you'd get before you would get a biopsy here, right? Like, this is some type of either granulomatous process or malignancy, I suspect. And so that would probably be what I would do next. So the goal was really to find the thing causing the 125 level.
Yeah.
And I think we've definitely identified a mass of some sort that's probably causing the problem. I don't know that there's a whole lot of labs I would get. I don't think it would be a terrible idea. I mean, this is not, I don't know if there's anything else I'd get before biopsy.
Okay. Okay. And that being said, would you just like me to show you some of the other things that were collected? Because I know, we talked about malignancy. I think you talked about like some like free light chains, maybe like multiple myeloma.
Yeah, like if you were concerned about multiple myeloma, I probably would have gotten those initially. I don't know that I'd get them now because this doesn't look like myeloma now, but early on, I probably would have gotten them while we were waiting for other imaging and such. Yeah, and then it looks like we got an ACE level, which is not a super specific test. And so is not always useful, but can be elevated in sarcoid. So I mean, that's certainly consistent with a diagnosis of potentially sarcoid. So not super surprising. Looks like SPEP, UPEP light chains were not consistent with myeloma.
Yeah.
So
you seem not surprised by those results. Because I think you already maybe have formed in your head where we're heading. Okay, great. Well, luckily we have our friendly pathologist to help talk about the biopsy that she did.
Okay, so from the pathology perspective, the lymph node biopsy from the station 7 shows a disruption of the normal nodal architecture as seen in here by specifically a collection of dense cluster of cells with light pink or eosinophilic cytoplasm as shown in here. In this next slide, we have the collection of those clusters of cells that are organized in a back-to-back pattern. In the center here, we can see a remnant of a normal lymph node follicle that is surrounded by the cluster of cells. Those cells are elongated. The nuclei is elongated, is curved, and the cytoplasm is granular and eosinophilic. And all of those morphological characteristics are more indicative of granulomatose formations. Here is a better image representing the back-to-back organization of those granulomas in light pink. And also we have spread follicles in blue or purple. And if we zoom in that picture, we can see a predominant large cell with multiple nuclei shown in the black arrow here. That cell is specifically called multinucleated giant cells. It is located at the center of the granuloma. Here is another picture of a multinucleated giant cell. We saw that in multiple areas of the tissue that we examined. There was no evidence of necrosis histologically associated with the granulomas. Here's another giant cell and associated with the granuloma. And at the periphery, we can see that small round blue cells, which are lymphocytes. Immunohistochemical studies with appropriate controls were performed for CD3 and CD20. On the left, we have CD3, which shows mixed T cells that are present in the interfollicular areas. And on the right side, we have the CD20 stain, which shows B cells located in the follicle. Additional studies were performed. GMS was negative for fungal organisms. Acid-fast stain was negative for acid-fast bacilli. And flow cytometric analysis was performed, and there was no evidence of no increase in blasts, clonal B cells, T cell population detected. So overall, the final diagnosis is non-necrotizing granulomatous lymphadenitis. Special stains were negative for fungal organisms. There was no evidence of acid-fast bacilli. And per flow cytometric analysis, there was no increase in blast, clonal B cell, or aberrant T cell population detected. Thank you.
Okay, well, also just FYI, they did this too and confirms what we also suspected. Okay, so I think I've taken up enough of your time. So again, your final diagnosis would be for this patient.
Sarcoidosis.
Yeah.
So I just want to give a shout out. I rode down the elevator with Kai Jones, who said to me 5 minutes before we started, I think it's totally going to be sarcoid.
Hi, how could you do this to me?
She did not know. She did not know. That was just her gut feeling. So props to Kai.
Okay, and just wrapping him up really quick. So this is the hospital course. It was unclear for a month span. Maybe he had hypercalcemia a little bit longer. You even had like those imaging studies that were clear, like they probably weren't the best ones to see the lymphadenopathy anyway. But I think it was like really the PET scan that helped show the enlarged lymph nodes, leading to the direction of going towards the biopsy. Endocrinology, of course, was on board, kind of like ran the show, honestly. Like they had these beautiful notes and like this beautiful like differential that they built. And then, of course, confirmation with the path results. This is just to show that, you know, you're concerned about like multi-system involvement. So you had like various teams on board, including Pulm and Opto. They were concerned about cardiac sarcoid and neurosarcoid, given his like syncopal episodes. They did do further workup with those things that we actually had looked at and weren't super convinced at the time. But Carl and I just like looked at his VA chart again, and they actually put in a pacemaker because now they are concerned about cardiac sarcoid in him. But I think no concern about neurosarcoid still. And then he was discharged on prednisone and hydroxychloroquine. And then it's been like 2 years now. He's still going strong, actually. And I think they switched him to methotrexate recently for management of that. And then maybe you obviously have much more insight into like hypercalcemia, sarcoidosis, like how often this is an initial presentation. I saw it's like not very common to see that as like one of the more presenting signs, but it is like a known electrolyte abnormality with sarcoidosis. So do you have like any additional thoughts about it?
Yeah, I would say relatively rare. I mean, I think my my sort of lens is a little bit colored by the fact that we only get involved with sarcoid cases when they present with hypercalcemia. But in my, now 15-year endocrine career, I think I've seen hypercalcemia from sarcoid 3 times. And one thing I do want to kind of highlight for you guys, so the treatment of 125 mediated hypercalcemia is steroids. And even if steroids are not the treatment for the underlying condition causing the activated 125 level, it will inhibit the 1-alpha hydroxylase, and so it will fix the hypercalcemia, even if it's not fixing the underlying condition or before you fix the underlying condition. So you treat the actual hypercalcemia itself with steroids in that situation.
Awesome. Okay. So thank you so much, Dr. Riek. Another sarcoid case. How can I do this?